Good afternoon, everyone. I very much appreciate you being here. At 3 o'clock in the afternoon is when my glucose levels tend to drop and I want to take a nap, so I commend you to be here because I know it's been a long day already. My name is Jami Smith, and I'm a faculty member at the Rutgers PA program, and I am passionate about simulation, and I'm very excited that you're all here to hear more about simulation because I think it is something that we really need to develop in PA education. We're going to talk a little bit about some specific parts of simulation and how to put it into PA education. This is by no means a comprehensive overview of things. We certainly couldn't do that in an hour's time, but hopefully enough to give you some interest and a little bit of snippets of information that you can use going forward in your programs.
Thanks, Jamie. I would like to echo Jamie's welcome to you all this afternoon to our session in Nuts and Bolts of Simulation and PA Education. And I'm Nina Multak. I'm from Drexel University here in Philadelphia, so we hope you're having a warm welcome despite the rain during your time here. That is when you get outside in between the sessions. And we would just like to get a sense from you all what kind of simulation modalities that you're using at your home PA programs. And we know you all are using something already and probably are interested in more. So I'd like to see a show of hands, how many people are using standardized patients in their PA programs right now? Wonderful. Almost all of you. Thanks. How about task trainers? IV arms, simulated skin? Wonderful. That's great. How many of you have at your PA program a patient mannequin simulator? Terrific. Also, a great number of you all. Super. So as you all probably are aware, all of those are types of modalities of simulation, and we'll talk about simulation as a whole, but we know that simulation can be used to meet a lot of learning objectives. And so neither Jamie or I have anything to disclose. These are some of the learning objectives. We want to talk a little bit about the literature for simulation modality, describe some resources that you can use to help support your simulation programming, and also talk a little bit about ARC PA standards, which you can use simulation to help your program meet those standards, and also some components or elements of a simulation scenario if you would like to use simulation or enhance your current simulation as part of a formative element of your curriculum or a summative testing element. So we want to talk about a couple of literature examples, and the first one, these are both very current examples. The first one is from a guy named David Gaba. Dr. Gaba is an anesthesiologist in San Francisco. He was one of the developers of one of the early simulation mannequins in the 1960s. It was further enhanced in the 1980s. He's a leader worldwide in simulation, and what he wrote about the diverse applications of simulation in terms of providing, training our providers, our student providers, to keep patient safety in mind. He talked in this article, which came out earlier this year in the Journal of Society for Simulation Healthcare, the different types of domains, the different content areas where simulation could be applied, the various types of learners which can use simulation, and PAs are alluded to, but we are included in a lot of the literature, the different types of resources and the different curricula that can be approached. And he really hit a lot of the nail on the head when he talked about the future uses of simulation and patient safety. And I encourage you to read that recent article as well as some of his previous articles. And also another recent evidence-based literature cited a number of best practices for using simulation in learning. Was by the authors that you see here, and it was built on a previous literature search that was encompassed 40 years. Initially, they found the 10 best practices for using simulation in healthcare education, and this recent article, which came out earlier this year, highlighted 12 best practices. Among them, they talked about debriefing or feedback. So debriefing is a type of discussion that you have with your learners, with your students, and so you use that as a way to incite them to think about their knowledge gaps. using simulation for deliberate practice, giving our students a chance to practice certain skills or practice an approach to a patient in various ways, such as a cardiac exam would be a good example, until they achieve proficiency. Team training, we see a lot of posters downstairs on interprofessional experiences in team training, and curriculum integration was another feature of the findings that they noted.
Okay, so that's a smidgen of some of the resources that are out there in simulation. There's many, many articles that are related to simulation in medicine and also in nursing. Unfortunately, not yet is there much regarding PAs and use of simulation. But hopefully, with this talk and other things you hear with simulation, it will inspire you to start doing some research and looking more into simulation, and we can build a body of knowledge. But so now you've read some research and you realize how great simulation is. It's been shown to improve patient safety. It's been shown to improve educational outcomes. How can we implement it into our programs? What are the steps and all the barriers that exist that we can use simulation to kind of work through? So generally, when you're implementing something, you need to establish the need for change. You need to do a needs assessment. Is this something that's very exciting and very sexy, and we have a very expensive simulator, so we should use it? Or does this make sense, and there's a need in our curriculum that this can help fill? Once you establish that there's a need, then you need to develop your goals and objectives. And goals and objectives, just like in any other part of education, are the key to decide where the curriculum goes and what needs to be done. So once your goals and objectives are developed, the next step is determining the best educational modality. Hopefully, not hopefully, but sometimes that will be sim. Sometimes it will not be sim, and there's plenty of other good educational modalities that we know that exist. But if you decide that it's sim, then you need to figure out how to put it into your curriculum. So once you do that, you need to develop your plan. What is the plan to make this change happen? How can you develop your resources? How can you inform your stakeholders? Where can you get the funding and supplies and things that you need? So you need to develop your plan to do so. Once you develop a plan, then you need to make a process to make sure that any problems that arise are addressed quickly and efficiently so that that doesn't become a barrier for future implementation or future use of simulation in your program. And of course, any time you're going to spend this much effort into making a curriculum, you want to make sure that its viability is secured. So can you get additional funding? Can you get additional resources to continue it and possibly even continue and provide some scholarship that will help the viability and longstanding of your curriculum? Okay, so what resources do we need for simulation? We need personnel, we need time, facilities, and funding costs. All the things in a PA education are just sitting around waiting for us to grab, right? Not exactly. So we may need to be creative and think outside the box and try to develop other ways to address these needs that we have. As far as personnel, so you need a curriculum director. You need your simulation champion to help push this through and make things happen. But as you know, with anything in PA education, things need to be collaborative. It's difficult in a program for only one person to be the simulation champion and try to do all the simulation that happens. It makes it very difficult. So in addition to having the curriculum director, you need to educate your faculty in how to use the simulation modalities, how to use the simulator itself, how to create a good scenario. A lot of education should go into how to debrief your students. So your faculty should all be comfortable debriefing because it is a skill that is acquired. It's not something that many people are able to do just off the fly. It's also important to develop your support staff. So you want someone who will administer your curriculum, develop the schedules, order the supplies, make sure the room is reserved, make sure everything that is available that you need for your curriculum. And you may need additional personnel like SPs. And then there's a whole other piece that goes into training SPs, scheduling the SPs, and doing things like that for the standardized patients, if that's what your simulation curriculum is focusing on at that point. Time. We all have so much time, don't we? Just throw in some simulation and no problem, everything will work itself out. So it's important to have time in the curriculum, and as we all know, you can't just keep piling and piling things on in PA education. If you're adding something new, something else has to be taken away. We only have so many hours in a day to do what we need to do. So it's important for the faculty to have time dedicated for curricular change, whether it be simulation or otherwise. It's also important for faculty development. So you certainly can't expect faculty to come in and be able to do simulation well off the start. They need training in simulation and training in debriefing at a minimum. There's additional time that needs to be set for the learners. So if you're adding something to the curriculum, what can be taken away? If there's time where they're actually in the sim lab, they may need additional time for preparation. So maybe you have some pre-reading or material that's online that you want them to view before they come into the sim session, so their time there is more effective. So you need to build that time into the curriculum, and also time that they're actually doing the simulation and having some reflection afterwards, so that their time is well spent. And again, support staff, people to help you do the scheduling, to help make copies of things, to order supplies that are needed, to schedule rosters and schedule the standardized patients and make sure that everything flows. All these people need to have time built in their schedule if you're adding something new into the curriculum. Facilities. So hopefully, who here comes from a PA program that has a nice big sim center? So you are all very lucky. Consider yourselves very lucky. Not all of us come from that, and just because you may or may not have that doesn't mean you can't do effective simulations. So the more you do sim, the more you realize you have to be creative, you have to be a recycler, you have to think out of the box. You don't always have the new and best things, but you still can do effective simulation by being resourceful. But ideally, you have some dedicated space for simulation. You have a place to store your mannequin. You have a place to actually have the hands-on type of activities that occur. You also need a place for storage. So where are you going to put all those supplies? How are you going to keep people from coming in and putting their hands all over that mannequin because it's just interesting and people want to touch things? So it's important to kind of have a separate space for your simulation activities. If you're doing something in a clinical setting, which may or may not happen. Sometimes in simulation, we do things called Nc2 Simulation, in which we actually go into a clinical setting and do simulation at the patient's bedside or outside the patient's room for those high acuity, less common types of things that happen in a clinical setting. And in that case, it's really important to think about access to patients and what sort of equipment you need in that setting. Costs. So nothing is free, and I know in many PA programs, funding is tight. So the question is, can you redeploy something that's already being spent somewhere else and focus it on simulation in your program? Or can you look for external resources? Can you look for additional sources of funding within your program or even from external sources? And the more that a curriculum has good, sufficient funding, the more likely that it will become scholarly and something that is of sufficient scholarly content that it can be published and the content be disseminated widely. So when you're obtaining support for the curriculum, you need internal support and you need external support. So by internal support, I mean the stakeholders. So who are the people in your program or department or school that make these sorts of decisions? You need to have your program directors on board. You need to have your deans on board. You need to have the people that are controlling the purse strings on board. You also need people to be champions of simulation within your program to help support the implementation of simulation. It's important to talk to these people in the beginning rather than at the end. You may go through all this planning process, come out to this really great idea, think you have everything figured out, and then you go back and talk to the people at the top and realize that this is just not feasible. There's no money, or there's no time, or whatever the issue is. So if you involve the stakeholders in the beginning and work through those barriers with the stakeholders, it's more likely that at the end your implementation plan will be successful. You may also need to develop conflict resolution skills. Hopefully that's not the case in your PA department, but sometimes that is something that you need to be able to negotiate and work politics in order to make your curriculum successful. Sources of external funding. So sometimes you need a start. You need a startup seed money to get things going. Once you have a curriculum that is started and successful, then you can go to your internal sources of support and ask for funding or ask for more resources. So there are things such as grants. PAEA gives a grant. Maybe within your university there's startup money. There's a whole list of agencies that potentially could be giving money for grants, but that may be a place to start to get your foot in the door and get things moving until you're more successful. As far as administration of the curriculum, so you do want an administrative structure in place. Again, lots of times you're the only person kind of starting things out in a simulation curriculum, so you may need to do a lot of these things on your own, but ideally you want to have a whole administrative structure in place to make things flow most effectively. You want to keep in good communication with the stakeholders, so you want to let them know when things are going well because you want to gain additional support, but also if you do have some barriers that you're dealing with, you may be able to get additional support, and it's important to keep those people in the loop as well. Make sure that you have people in an operations form, so they're making sure that day-to-day things are going within your curriculum the way you want them to go. It's difficult for a faculty member to come in and be able to do all these different things at the same time. And sometimes when it's new, you have to, but as you start to develop the curriculum and it becomes bigger, you want to pull in these additional sources of support for you. And scholarship, I can't say enough how important scholarship is in PA education. We're not that new of a profession anymore. People know who we are and what we're all about. It's time to really get into the literature and show some of the things that we're doing in education and why they're effective to our particular student population. As far as barriers, there's lots of barriers, potentially. Compensation's a barrier. You may or may not have your time compensated. This may be something that's added to your faculty workload already. I guess it depends on how much of a sim champion you want to be, whether or not you want to take on that additional responsibility. But it's something that maybe once the curriculum is shown to be effective, that could then be renegotiated and be more equitable. Personnel certainly can be barriers. So if the rest of your faculty are not really interested in this type of educational modality, you may need to garner some support. We're going to talk a little bit more about ways to do that, and one of those may be to show how we can match simulation to ARC-PA standards. Another is to start being more familiar with the literature and the research that's out there and to really show that this is working in nursing and medical education. Hey, maybe this is something that could work in PA education as well. Okay, so now Nina's going to talk about the simulation scenarios.
Thanks, Jamie. So these next few slides will talk about components or elements of simulation scenarios. And one of the things that we really need to think about is, to begin with the end in mind. What are we trying to learn? What are our student outcomes? And what will we eventually try to assess via simulation or via written test of knowledge about our students? The first thing you may want to consider is to identify, as I said, identify the learning outcome and the focus of your simulation and create a title for your simulation scenario. You may label all these by the year, by the course you're going to teach it in, or by the domain or the medical content area that you would like to include. The next thing you want to think about are the scenario participants, and this could be students or other people. Are we just going to use PA students in our simulation scenario? I should say, is this a case-based scenario, or is it not a non-case-based scenario, just an exercise in skill evaluation? Do we have access to other people who would like to collaborate with us via simulation? Our institution, dental students are doing a lot of simulations, not only dental simulations, but medical complications which might occur in a dental office. Nurses are doing a lot of simulations, and medical students and residents. And the other thing you might want to consider, if you haven't already used it, is some of your standardized patients may be part of the simulation scenario. And we commonly use standardized patients as Confederates or family members. So if we have a case about a geriatric patient, we may have a standardized patient in our scenario as a Confederate to add another dimension to the case, such as delivering bad news or DNR orders or something specific that would dovetail into our learning objectives for that case. So you want to set all that out ahead of time because, as Jamie mentioned, that one of the things to concern are our personnel and our resources, and any standardized patients or other participants from other programs would need to be contacted ahead of time, sometimes 6 months ahead of time, maybe a Confederate or a standardized patient 6 weeks ahead of time, but you want to consider the participants in your scenario, because if they're not just PA students, that adds a different layer of complexity to your planning. As I alluded to, the content, we want to think about what we want to address there. Do we want to consider one purpose, more than one purpose? Do we want to have a standardized patient or a mannequin simulator for exam skills? Do we want to have our scenario content be use clinical decision-making as an emphasis of our scenario? What area of medicine are we going to choose? Should we choose clinical decision-making? Do we want to use this case for our didactic year learners or our clinical year students when we call them back on their post-rotation visits back to campus, if that's something you do at your institution? Do we want to assess their ACLS skills? I've listed here cardiac, respiratory, or pediatric topics as common domain areas for simulation scenarios. Again, depending on your learners, you may choose to have the same case for your didactic learners, but add some more complex issues for the students to address if they're clinical year students versus if they're didactic year students. So these are some of the content issues. I mentioned learning outcomes. You want to develop these as you develop the case. You don't want more than 3 or 4 objectives for your case scenario. You want to consider things that you can measure so you can identify if the student has successfully achieved these learning outcomes, or if it's a skill, maybe a mannequin-based case, and you may ask the students to do some kind of, perform some kind of skill, start an IV on the mannequin as part of a summative assessment for this particular case. So again, 3 to 4 objectives for each case. Setting the stage, we want to decide where are we with this scenario? Where are we simulating that we are? Are we in the clinic? Our simulation center is set up like an ED, so do you want the ED to, sometimes we convert it to an underserved area, somewhere, a rural warehouse in Philadelphia. We've changed the scenario to be the Dominican Republic. We bump up the heat to like 90 degrees, and we have audio of birds chirping and a little campfire in the corner, and then all our SPs dress up either like tourists or victims or whatever we decide the case is. So you want to choose what your scenario is, and depending on your staff and resources, decide to do that. The other choices, as Jami mentioned, might be to do an Nc2 simulation if you don't have a lot of space, and arrange for the ED or the local clinic that you might use for SP encounters to go in all of a sudden and have a surprise simulation in one of those locations. Again, we also want to consider the participants. I talked about the SPs and the students, but what should each person do? How many students do you want in each scenario? And how many patients or simulated patients do you want in each scenario? So if you have not enough time, you will want to decide, what will my students do when they go into this case? Are there 2 or 3 students? That's great. Are they all going to be pretending to be the PA or giving the care? Or will one have another role? The participants, if you need someone who's a role other than a PA, ask someone to be a family member, or you can ask somebody to take on some other role in the medical environment and tell the student ahead of time, this is your role during this case. Or do you want them all to, as didactic students, to collectively take a history and maybe perform different elements of the physical exam? So you want to let them know what you expect of them before they go in, because in order for them to sustain belief in this, we ask them, we tell them, we know the mannequins are plastic, we know this isn't a real situation, but try to immerse yourself and suspend that disbelief for a few minutes, and they can engage with the scenario and the simulated role such that they actually will behave as you're anticipating they might if you give them the appropriate participation or role. Scenario timing. Typically, simulation scenarios will last 15 to 20 minutes, usually closer to 15 minutes. Depends on what your endpoint is in the simulation. If the learners achieve their goal, you'll have a couple different paths they may achieve, and if they're going down the wrong path, you may have to make some changes on the fly and say, gosh, they didn't notice that the respiration rate was only 6. We're going to have to send in a Confederate to say, oh my gosh, it doesn't look like my patient is, my family member is breathing, or a nurse, someone as a nurse Confederate to say, does anyone have any idea what they're doing in here? So some kind of little nudge to, prompt the students to go the path that you want. And in fact, a lot of the learning we'll be talking about after the scenario is over. So again, about 15 minutes for your case, 15 to 20 minutes, and you'll want to provide ample time for a debriefing afterwards. So the debriefing will be can be up to 3 times the length of your actual case scenario, depending on the modality, the type of debriefing that you choose to use. And there are several that are available. Some are plus delta, which we discuss at the bedside, where you tell them what they did really well and you tell them what they could have changed, and then talk about the case content and other issues. That's very common in PA education to our knowledge so far. Another type that's commonly used is debriefing with good judgment, where you say, gosh, I see that you did X, Y, and Z really well, and you might be wondering why on earth they didn't, resuscitate the patient or administer a med. Instead of saying, why didn't you do that? You'll say, can you help me understand the reasons behind your actions, so that we're encouraging them to do some self-reflection and come back to us with their rationale. What are they thinking, and can we help them as clinician educators to bridge that gap between where they are as student learners and where we want them to be as really, safe clinicians who have patient safety in mind. When we continue to develop our case, we'll want to know what the details are of the background of the patient. What's the medical background? I would usually typically just, write up a little case vignette like we do for exam question stems, include information, an HPI, a past medical history, drug and allergies, or social history, whatever you want the patient to have or possibly have if the student asks the right questions. You may want to consider some simulated patient data. A simulated EMR might be possible. You may have access to one if you're teaching your students at your institution. You may just use paper. If you're doing a low resource type case, you may have nothing or give them a scratch paper or just tell them to bring their own note paper. And you'll decide what kind of clinic chart that you want to have. There are a lot of options to consider. And if you're using a mannequin, you'll want to note these basic settings that you want to start the scenario out. Some of us will be responsible for being the mannequin operator as faculty members, and other times you might have the good fortune of having a simulation tech to help you set or change the parameters of the mannequin. Other times, some of the mannequin products allow you to program the mannequin for the direction of options that you would like. So it can link certain vital signs in sequence to each other, and you can decide how long you want between the intervals of the change in each vital sign or each action that you may want changed on the mannequin. You may need, some things like pulse oximeter or ECGs. We have some defibrillators. You may want the students to have access to that. The other thing is, if you're using a mannequin, what do you want the patient to say? Because you may not be the one behind the mannequin's voice. So do you want to use the pre-programmed voices, or do you, as a faculty member, one of your faculty colleagues, want to be the voice of the mannequin? Or do you want to get a standardized patient to be the voice of the mannequin and give them a script of the kind of things that they should say? A couple of things to consider. The vocal sounds and their responses. Supplies and equipment. We talked a little about the clinic supplies. The supplies should be appropriate to the environment you're trying to simulate. So clinic supplies or ED supplies, or nothing if you have low resource, or trauma bay situation, what type of chart or electronic medical records you like, if any emergency response equipment, or other things. Down at the bottom of the slide, we have listed something about participant instruction. It's a really great idea, just like we do at the beginning of a course. We give the students a syllabus. We sometimes upload, if we have a learning management system, we upload it to there. What can you expect in this course? And we do the same thing with simulation. What can you expect out of this learning experience? And we'll tell them, this is going to be a cardiac case. Bring your stethoscope and bring something to write with. And maybe it's also about communication to team members and other team members. There's going to be a telephone in the room. You can call for help. These are the simulated things that are lifelike that you may want to consider. So they have an idea of what to do. If I have a number of students, I may let them decide what role. If I'm looking for leadership in a team, I may say, you guys go in, here's the case, and decide what role, and see how the role decision evolves. Or I've given them a little index card and say, if we're doing a resuscitation event, this is your role, or the team leader will decide on your role. So some kind of instructions, this is what you can expect. I think that they seem to respond better when they're not in total surprise and they're a little bit prepared. We'll have a debriefing plan. One of the things we talk about is simulation safety. And so we come to the simulation environment with a number of assumptions. One is that each student who's there wants to learn, wants to do their best, and wants to reflect that in their actions. So we tell them, if you see someone who maybe administered the wrong medication or didn't know the right dose of the medication they're going to take, that should stay here in simulation. And when you go to lunch with your student friends, you shouldn't be sharing that, so-and-so, made this error. So errors, simulation is a safe place to make errors and places for students to think that, and understand that their actions are to be learned and built upon. We want to, as instructors and faculty, let the students do the talking. We want to facilitate their comments and responses to their actions. So we want to see if our learning objectives went, but we may ask the students immediately after a scenario, what did you think about that? Or how did you feel? And they'll say anxious, surprised, unprepared, or very prepared. So they'll give you a whole host of responses. And then you may ask, what didn't go so well, or what did you learn? A couple of questions that are listed here that you may want to use. In terms of evaluation and assessment, we have opportunities. I know all of you have, when you develop your OSCEs, a summative blueprint and grading rubric you have for your students. When you consider mannequin-based simulation, there are a number of assessment tools that have been developed. Most of them are for the nursing and medicine medical resident population, medical student population, and certainly we can have an opportunity to discuss with the colleagues what you're trying to evaluate, if it's a skill or knowledge, and decide on what's the best way to evaluate your student learners.
Okay, so again, you've decided that this is something that you want to be a champion of. You want to do more simulation in your program, but how do you sell it to the rest of your stakeholders? How do you get everyone else to understand how important it is? So one of the ways, we know how important the ARC-PA standards are and how we need to tie what we're doing to ARC-PA standards. So I'm going to talk about a couple of standards. This is way too many words for a PowerPoint slide, so we'll break this down and go through each of these separately, but you can see that there's 6 standards right off the top that we can use to match to simulation modalities. Okay, so the first one is B107. The curriculum must include instruction related to the development of problem-solving and medical decision-making skills. This is my personal favorite standard for simulation education because I feel like it's so wide open. There's so many things in simulation that you can do that could meet this standard. So just an example here, you could have your high-fidelity mannequin with a complaint of chest pain. So part of the evaluation would be to do the history, physical examination, determine appropriate diagnostic testing for this patient, interpret those tests, and then develop a treatment plan. Depending who your student population is, whether this is a didactic learner who, for the first time, is putting their hands on a simulator, or this is a clinical year student, depends on what your scenario could look like. So if it was a didactic year student who you probably have taught a lot about MIs to, you may want to make that classic 50-year-old male who's diaphoretic and nauseous and clutching his chest, very textbook presentation of an MI, have classic EKG findings, and work through that scenario. If it was your clinical year student, you may want to have that 68-year-old female with a little nausea and epigastric tenderness or epigastric pain who ends up having some less obvious findings on her EKG and still goes on to have an MI. So the idea is that you start to incorporate some of the zebras in your clinical year, some of the higher acuity, more complex scenarios, and more straightforward things in the didactic year. But the sky's the limit with what you could do with this. You could have any sorts of complaints and then work your way around, again, depending on your goals and objectives. I do want to just talk about that for a second. I know that sometimes we walk into scenarios or situations where someone will say, hey, here's a simulator, use it. And the question is, should we use it? And it all goes back to your goals and objectives. So I really think that's such the important point to stress here. Your goals and objectives, the simulation needs to reflect it, because simulation is just a tool to carry out your goals and objectives. But if you don't have refined goals and objectives, your simulations can go completely off track and be very complex for not really a good learning purpose. So it's really important to keep those in mind. Okay, so back to our scenario. What do we need for this? A high-fidelity mannequin, and what that means is a mannequin that can respond to what the students are doing. So this is something that you may have in your practice or in your educational setting, a SimMan 3G. Those are some examples. There's certainly lots of other examples of that, but the idea is that they're high fidelity. Or you could have a standardized patient. If this was during your didactic year and the focus is the history and physical, less so maybe the resuscitation of this patient, then a standardized patient may make more sense because they can actually interact with that person more effectively than with a mannequin. So don't think just because you have a mannequin you have to use it. Think about what best meets your goals and objectives and then use the tools that fit that. We did something similar to this recently, and we had a faculty member who acted as a standardized patient, and it worked very well. And then also, in this scenario, you'd want a cardiac monitor. Maybe you wouldn't need that depending on what your goals and objectives were. So the next ARC-PA standard is B108, and the curriculum must include instruction to prepare students to work collaboratively in interprofessional, patient-centered teams. So interprofessional, we're all hearing about this thinking, how the heck can I make an interprofessional educational session when I'm just in my program and I may not have a lot of collaboration of other schools around me? So depending on what resources you have available, obviously depend on what you can do. In this scenario, the example was from a medical school where there was residents, nurse practitioners, PAs, nursing students. So they all came together and worked on an obstetric case. The case is something called a longitudinal case, and this is often used in clinical settings where a patient may present to the ER, be evaluated, and move to the next section in the hospital, like the surgical center. So they may kind of work through that setting, so it's called a longitudinal case. And in this particular case, the patient presented, she was 34 weeks pregnant with severe acute abdominal pain, some vaginal bleeding, and was found to have an abruption of her placenta that was diagnosed in the ER. She then moved to be evaluated by the OBGYN team, anesthesia came in, nursing, and she was taken to the OR for a stat C-section. So the idea is it can be as complex or as straightforward depending on what resources and time and personnel you have available. But in this setting, there are lots of different learners who all can work within their roles, but at the same time, they're working together as part of a bigger team. One thing I will say about this is that it's important to make sure that your learners are leveled. So it's difficult to pull in a third-year ER resident, second or third-year anesthesia resident, and an undergraduate nurse, and put them all together in the same sim and expect it to be effective. There are people at very different levels of their education. So keep in mind that if you're working with PA students, you may not want to have a first or second year medical student. You want to have the higher level medical student working with the PA students. You would want to have a higher level nurse so that you're closer in level, and then when you're going to debrief and trying to understand what happened, people have more similar expectations and the learning can occur at a higher level. In this particular modality, we used another high-fidelity simulator, so this was actually one that can simulate childbirth and standardized patients as well. So we combine the two together, and that's called a hybrid model. So hybrid can be a standardized patient and a high-fidelity mannequin. It could be a standardized patient and a task trainer. There's lots of variations that can go together. So you can also throw in things that are called Confederates, which Nina alluded to, and that's just someone to come into the role to kind of add a level of complexity. It could be a spouse that's unhappy, it could be a family member, it could be the parent of a pediatric case, depending again on what your goals and objectives are. Okay, so B204, the program curriculum must include instruction in interpersonal and communication skills that result in the effective exchange of information and collaboration with patients, their families, and other health professionals. So effective information exchange. So many of you probably, or all, may be doing OSCEs already, and that's a great example of meeting this ARC-PA standard for effective information exchange. Another one could be a hybrid scenario where you're using a mannequin, you're using some sort of task trainer or even a high-fidelity mannequin to do a specific task, but in addition, you're working with a standardized patient to get some communication information that's exchanged. So you could use your standardized patient, you could use a high-fidelity mannequin with a Confederate family member, and you could have a scenario where someone calls for a consult. So one way that you could do this could be an elderly patient who has acute mental status changes. Could be the mannequin. So they're not very responsive. You can't get much of a history from them. And then you have the family member who might be the wife who's giving some information. And maybe it's determined that the patient's pretty sick, and maybe part of your goal and objective is to talk about end-of-life decisions. Does a patient have a DNR? How do you ask someone if you have a DNR? If they say, oh no, does that mean you're not going to resuscitate my husband if he's unwell? How does a student have that conversation? So again, depending on your goals and objectives, there's lots of ways to accomplish that effective communication exchange. One thing that I found in some of the one of the programs that I worked was that some of the students didn't feel very comfortable giving communication to a consult. So they're calling the internal medicine physician on the phone to give a report of the patient, or they're calling for a specialist, and they just didn't know how to organize all their thoughts quickly together to make a good summary of information that need to be communicated. And one of the ways you can work on that is to end a scenario by calling for a consult. So you had the patient with the MI, you determined it was an MI, you started appropriate therapy, but now he needs to go to the cath lab. So to get the team on the phone from the cath lab and have the student kind of sign out that patient to the cath lab. So they're working on communication skills, and they're working on lots of other pieces as well. As you can see, some of these flow back and forth into each other. It's not always just one scenario to meet one standard. Sometimes you can hit multiple standards with one scenario. The program curriculum must include instruction in the provision of clinical medical care across the lifespan. I sometimes think this can be one of the more challenging ones because it's sometimes difficult when all of our students are generally young 20, 30-year-olds who aren't at the population spectrums of age. How do you get a realistic encounter with these age groups? One option would be to have a geriatric patient as your SP. So they may have a complex medical history. They have to go through this full history and then do a physical exam on a normal geriatric patient, which is going to look very different than the 20-year-old they practice doing their PD practical on. So just that in itself, goes into the lifespan. So you may have also talking about code status, end-of-life choices, some of those difficult conversations to have, and they could be simulated with a standardized patient in real time. Something else that's difficult, I don't know about you, but my program does not have a whole list of expectant mothers on the list waiting for that pediatric module to come up that you can call them and bring all their babies in. It's difficult to get your hands on babies or the students to get their hands on there and really get a good physical exam. I don't have a magic answer for that. There is a really expensive high-fidelity mannequin that you could use, but again, I think for the purposes of physical exam, it can't be simulated quite as normal, but you could focus on some of the other things in pediatrics. For example, suppose you have a doll and a Confederate, meaning somebody who knows the scenario. The students interact with this Confederate, and the problem is that she absolutely does not want to vaccinate her children. Absolutely not going to happen. And how does the PA student react to that? How do you convince someone to do something that you believe is correct and is best for their child or for themselves? How do you work through that as a student? What kind of conversation do you have? And it could be, something like dietary modification. It could be someone who smokes. But in this particular scenario, you could focus on the pediatric version of that. Another option for pediatrics would be to take a baby doll that is not very responsive and focus the scenario on the mother away from the child, but moulage or trying to think of a word and it's gone. Moulage or try to disguise the child in a way that would make them look like they were abused. So maybe put some bruising on the head, some bruising on the torso, have part of the evaluation that there's an x-ray that shows classic findings, a bunch of non-healed fractures on the child or multiple rib fractures. So the PA student should realize that this is an abuse case, and then they have to talk about this with the mother. And how would they deal with that? How would they let the mother know that they're going to involve social services and that the child would have to come into the hospital into custody? So again, these are higher level things to work on with students, probably something that would be more applicable to the clinical year, but they're things that they'll encounter in real life, and this is a way to bring that realism into your classroom. As far as modalities, so I mentioned geriatric SPs or high-fidelity mannequins. Again, I think that depending on what your goals and objectives are, you may not need these high-fidelity mannequins. You can use other means to accomplish the same goal. And B207, the program must include instruction and technical skills and procedures based on current professional practice. So I think this is also another ARC-PA standard that's relatively easy to hit when it comes to simulation. So one of the things that you can use are task trainers, things like for urinary catheterization, putting in IVs, injections, lumbar punctures, central line suturing. If you can think of a skill that needs to be done, chances are there's a task trainer out there to do it. So certainly that's something that you could use. The other thing that you could use is to combine high-fidelity simulators into the tasks that actually need to be done. So you could have a patient who presents with an acute tension pneumothorax, and you want the patient or the students to needle decompress that tension pneumo. You could have them place an interosseous line. You could have them do CPR and maybe CPR skills and defibrillation. So you certainly don't have to only use task trainers, but you could have a whole patient scenario and a task trainer off to the side. And suppose it's a 68-year-old male who comes in with abdominal pain and decreased urination over 2 days. They evaluate the mannequin and find that he has acute urinary retention. They could then go to the side and there's a task trainer and they could practice putting in their Foley catheter and interpreting lab values that show acute renal failure, for example. So there's lots of different ways that you could weave things in together. Okay, and the last standard focuses on patient safety, quality improvement, prevention of medical errors, and risk management. So a scenario that you could have could involve an incorrect administration of a medication. So one of your Confederates could be a nurse and have a patient with an obvious musculoskeletal abnormality, a shoulder dislocation, a trimalleolar ankle fracture, where they're in tons of pain. They're very unwilling to give a good history because they want lots of pain medication. The student likely would then say, okay, I'm going to order something for pain. You have the Confederate nurse come and give a big dose of pain medication that's the wrong dose. The patient then has an opioid overdose, and then the scenario has to unfold where how do you admit a mistake was made, even if it wasn't your mistake? How do you communicate that to the family? How do you communicate that to the patient? So that's one way you could do it. Another way is to work on team management skills in the midst of resuscitation. So in the midst of ACLS, things you could work on: crisis resource management or crew resource management skills. And those are things like identifying a leader, assigning roles, using a shared mental model, and using closed-loop communication. And those things will help your students develop lifelong skills and effective team communication that they would actually use in a clinical setting.
So as we wind up this talk, we want to mention that it's important to use the literature that's already available, that's been done over the last years in simulation, to educate yourself, and use them to educate people at your institution, your program directors, your deans, your other institutional administrators on the effectiveness of simulation modalities for student learners. And the other thing is we need to remind you that simulation shouldn't be an adjunct to the curriculum. It should be implemented, as Jami mentioned earlier in the talk, into your curriculum, woven in, and the studies have shown that if you require the students to attend, the outcomes are better. So don't make it a voluntary activity. It may not be a graded element. It may be one of your other learning activities like your lectures, but requiring students to attend will ensure better outcomes with their learning. In summary, we just want to, reiterate that healthcare simulation has been extensively researched and widely published and presented all over the world with increase in volumes over the last decade. It's a modality that now it's our time as PA educators to use and to do scholarly research about the effectiveness of this in the global environment. The nurses did a big study recently about use of simulation in lieu of clinical training time. We may want to have conversations in light of decreasing clinical sites and maybe decreasing funds to supplement that gap. How to use simulation to teach and assess our students. We do want to mention that we had in the last few days a pre-conference workshop on simulation, well attended by a number of your colleagues, and your presence here shows the increased interest. We have a simulation interest group tomorrow morning at 7 o'clock. For anyone who would be interested in furthering the discussion of simulation use in PA education and scholarly work. And we encourage your participation, and thank you so much. If anyone has any questions, Jami and I will stay up here for a few minutes.